Hello, welcome. We're really glad you joined us today. So let me introduce you to our team today. So first, we're going to have Mutaz Shegewi from IDC join us. And then we'll be joined by Michael Marchand from UC Davis, and then I'll be moderating a discussion. So let me start with Mutaz. Mutaz Shegewi is a research director, worldwide provider IT transformation strategies with IDC Health Insight. Mutaz Shegewi leads the provider research practice at IDC Health Insights, covering topics of most relevance to healthcare provider organizations looking to digitally transform and become more digitally native than their competition. Mutaz advises the executive, clinical, and technical leadership of the world's foremost health information technology supplier and buyer organizations by producing data-driven research and thought leadership insights to help to navigate strategic challenges in health information technology and transform complexity to clarity in decision-making. Mutaz focuses on research areas that help providers reduce costs, enhance quality, optimize access, improve patient safety, and champion the patient experience. Our next speaker is Michael Marchand. He is the Director of System Integration and Health Information Exchange at UC Davis in California. Michael has spent the last 25 years implementing complex technology and integrating data in his leadership roles for leading healthcare organizations. Michael has spent time working with and for application vendors, provider organizations, and government entities, leading teams and delivering needed solutions, advancing technology, improving workflows, and supporting interoperability within his organization and with others locally and nationally. As a former member of the HIMSS Interoperability and HIE Committee and his current roles serving on the HIMSS Blockchain Task Force, Care Quality and Consensus Health Advisory Boards, and Health Technology Alliance Steering Committee, he is involved in shaping organizational directions, policy, content, and messaging, as well as helping raise awareness of emerging trends in technology in healthcare. Michael's current role as Director of Health Information Exchange and System Integration for UC Davis regularly challenges him and his team to solve complex technology and interoperability challenges for his organization and the greater community. Michael is passionate about moving technology forward that connects patients and their health information and allows them to control who has access, where, and when through his work. And I'm Linda Rowe. I'm Senior Advisor of Value-Based Markets at InterSystems, where I'm subject matter expert around the shift to value-based models. I share my expertise with customers and the industry through my speaking engagements and published papers. For the past 2 decades, I've had senior positions in health information technology. I've worked with payers, health systems, startups, vendors, and the federal government. So our agenda today, Mutaz is going to open, and he's going to introduce everyone to the concept of the digital front door. For those who aren't familiar with it, he'll give an overview and an orientation from IDC's perspective, and they've done a lot of research around that. Next, we'll hear from Michael as he describes UC Davis's digital front door strategy and how he's been building that since 2019. And finally, I will be having a moderated conversation with Michael where he delves in a little deeper on some of these topics.
Good morning to you all. My name is Mutaz Shegewi. I'm a research director at IDC Health Insights and lead the worldwide provider IT transformation strategies practice at IDC. I'm thankful for the opportunity and delighted to speak to you today about the digital front door in healthcare. There's been a lot of buzz and interest on this use case across the provider, payer, and life sciences verticals, but at the same time, some lack of clarity regarding what a digital front door is exactly and how to go about implementing one. And so for the next 15 minutes, I'm going to speak to you about the digital front door, which I believe to be a very timely discussion as we see this use case accelerate and mature across the industry. With that, I'd like to extend a warm welcome to you all as we embark on an accelerated journey into understanding more about the digital front door. And in terms of the agenda, we'll begin with an industry overview that briefly looks at what is top of mind for healthcare. I'll then transition into a more detailed discussion on the digital front door. And finally, I'll conclude with some parting thoughts about the future of the digital front door use case and share with you a simple playbook that offers some guidance on how to think about digital front door technology initiatives. And so by the end of this presentation, you will have gained an idea of industry trends that have advanced a digital front door strategy, the architectural components of a digital front door, and its benefits, particularly for patients. Let's begin with an industry overview. If we look at what is top of mind for healthcare from a health IT standpoint, we see the industry continue to evolve on its digital transformation journey, which for many started well before the pandemic and which the pandemic accelerated. We see health IT continuing to evolve as providers and payers navigate their ways towards the next normal. For providers, there continues to be rapidly shifting priorities from the pivot to virtual care during the initial pandemic wave to vaccine management, and now toward recalibrating clinical documentation, revenue cycle management, and digital patient experiences with the introduction or optimization of next generational solutions, platforms, and workflows in those areas. If you think about front-end service optimization for better patient access, such as through open access scheduling, more virtual care integration, and deploying conversational AI chatbots, which all tie into the digital front door, which I'll come back to shortly. Data proliferation is continuing to impact everything from storage to security, and interoperability, which, as we all know, is gaining even more momentum, is helping to scale the use of data across disparate systems under the health IT certification requirements for the 21st Century Cures Act final rule. And of course, the focus on cybersecurity and resilience due to the ongoing expansion of new digital footprints, attack surface areas, and potential vulnerabilities being introduced into health IT environments. With that, we see digital transformation, or what we often refer to at IDC as DX, continuing to be unleashed to address the long list of pre-existing and emerging challenges in healthcare, many of which you are already familiar with, but which range from aging populations to more chronic conditions, the shift to value-based care, to expected talent shortages, alongside other challenges like the rise of consumerism and cyber threats. The response is one of next generational emergence that sees disruption more as being about the need to infuse digital resiliency into the organization through health IT initiatives. For example, everything from cloud-based platforms and ecosystem-based partnerships to emerging technologies like AI, RPA, IoT, and interoperability standards like HL7 FHIR. The key takeaway is this notion of intelligence in action and how healthcare organizations want to shift from being data-rich to data-driven, and where organizations use health IT not only to do routine tasks like clinical documentation in the case of EHRs or billing in the case of RCM, but to answer important questions through the data to support better clinical decision-making and to make relationships more meaningful with patients and between staff. And all of that requires better aggregation, integration, and orchestration of data from multiple sources to improve outcomes. And I always refer to a mnemonic when I talk about outcomes, which is CQASE, short for cost, quality, access, safety, and experience, or the core outcomes we should always be striving to improve in healthcare. And ultimately, healthcare organizations appear to be aspiring for an ideal end state of data excellence where intelligence in action shapes and drives the organization towards more differentiation and a better future of work. And in hindsight, we saw some very interesting data on the pivot to virtual care between March and May of 2020 when COVID-19 was starting to take hold, and that 83.9% of some 1,500 US respondents we surveyed who had a care visit during that time had a virtual care visit for the first time. And where 1 of 5 downloaded a virtual care application in advance of needing it, and 72.5% interacted with a front-end conversational AI chatbot or symptom checker. And so these data points were quite remarkable and showed that the industry did transform very rapidly in the battle against the pandemic. We often refer to this notion of 2 years of digital transformation having happened over the first 2 months of the pandemic. And this all helped pave the way for the emergence of the digital front door. Now that we covered an overview of the industry, let's take a deeper dive into the digital front door. And there are many descriptions and interpretations about what a digital front door is, depending on who you ask. At IDC, we define it very clearly as being all the touch points where providers and payers can digitally interact with patients or members to drive better access, engagement, and experiences across the service continuum. This is about a true level of detachment from the old ways of doing things, with this emphasis on better access, engagement, and experiences. The digital front door gravitates healthcare towards a more consumer-friendly, patient-centric paradigm powered by digital touchpoints across the service. And I introduced this framework back in May of 2020 at the height of the pandemic here in the US to help take our definition further through a visualization of the use case. The digital front door should be thought about as a vast array of technologies and capabilities, or a digital vehicle or fabric of sorts that spans across the service or the continuum of care, starting from the point of initiation on the left-hand side of the slide, or when an individual first comes to this realization that they need to get care, through the various stages of the service in the middle, all the way to the stage of follow-up on the right-hand side. So the digital front door, in this sense, is not a literal front door or front-end initiative that points individuals to brick and mortar or engages them through a single or limited group of point solutions like open access scheduling and or a telehealth integration, but rather it's a strategic mix of technologies with capabilities positioned across the service that allows care to be scaled to meet the patient where they are through this kind of holistic health IT endeavor that is scaling the digital and virtual care experience. To appreciate this better in a day in the life of a provider who has already deployed a robust and advanced digital front door like you see here on this slide, patients who do not need to be physically seen would undertake the entire care journey from left to right without needing to step foot into a physical brick and mortar facility like a hospital or clinic, by using everything from open access scheduling to book their appointment, to being virtually triaged by a front-end conversational AI chatbot, and then seen through a telehealth enabled virtual visit, which of course would be integrated with the EHR RCM suite, the clinical documentation and billing, and all the other technologies needed to run analytics, to achieve interoperability and to enhance the patient's experience, such as CRM tools. And there are multiple benefits to unlocking the digital front door in this way by ramping up front-end patient access and service optimization, and combining that with this consumer-centric virtual care and digital service delivery model under one kind of end-to-end platform initiative with automation and empathic intelligence that builds on data that is relevant and meaningful to the patient as a person. The benefits are that the digital front door not only scales the service to meet the patient where they are, but delivers value beyond the physical walls, which has a positive impact on cost for patients and resource burden for staff, and experiences for all, because the care process, it becomes digital and virtual rather than physical. With that, resiliency becomes infused, since inbound demand is softened through virtual service delivery. That conserves physical capacity, yet still delivers value. And in the pandemic, this helped the response by decreasing the likelihood for cross-infection between patients and staff, if not eliminating it all altogether. So the digital front door has multiple benefits when you look at it collectively. I'd like to conclude by sharing some parting thoughts about the future of the digital front door in healthcare and how to go about thinking of digital front door initiatives, especially as the lines continue to blur between providers and payers, and with this push for more personalized medicine and more convenient and satisfying experiences in healthcare. At IDC, we recently published a prediction in our Futurescape report series based on our research data that offers a glimpse into the future of the digital front door and its impact on healthcare. The prediction states that by 2023, 65% of patients will have accessed care through a digital front door, as healthcare providers look for better ways to improve access, engagements, and experiences across all services. And you can see from the figure on this slide, the positioning of the prediction amongst the 10 other prediction topics, with the X or horizontal axis representing the timing of the prediction to reach mainstream adoption, and the Y or vertical axis representing the cost or complexity to address the initiative. And I did want to call out some of the best practices that we've been observing in the industry when it comes to digital front door initiatives. And these range from digital mapping and gap identification, prioritization of the right technologies and capabilities to fill the digital gaps, in addition to the right integrations and interoperability plays to tie everything together, identifying the right vendors through educated engagements and informed decisions who can deliver on those needs, and evaluating the initiative through an outcomes-based results orientation, and always keeping in mind kind of those core outcomes that I touched upon earlier, the mnemonic of CQASE: cost, quality, access, safety, experience, at the least. The key takeaway is that the digital front door is a team sport. It combines the views of clinical, IT, business, and consumer stakeholders into one. I'd like to thank you all very much for attending. I hope you benefited from the presentation. I'm happy to take any of your questions at any time. You can find my contact information on the final slide in the slide deck. Thanks again.
Thank you so much, Mutaz. That was a great introduction for everyone to the digital front door. And now I'm going to transition it to my colleague, Michael Marchand from UC Davis, who's going to give you his journey to the digital front door and how they're approaching it at UC Davis. Michael?
Thanks, Linda and Mutaz. Appreciate all the great sharing that you've done there. So I'm Michael Marchand. I'm the Director for Interoperability at UC Davis. I'm just going to talk to you about our journey to the digital front door and really opening up access, data liquidity, freeing the data, so to speak, and our journey and kind of how we went from concept to reality or working our way there. First, I just want to share a little bit about UC Davis. We're an academic medical center in Northern California. Your basic stats here, number of beds, number of staff. And really what we're looking at is coordinating the care for patients in the Sacramento area. We're an academic medical center that takes a lot of referrals, and we see a lot of patients from a lot of different organizations, and connecting with those organizations is a prime directive for us, and making that a frictionless interaction and unlocking those APIs and the data and creating a digital front door are key to that strategy being successful for our community. So just a little bit about where we started looking at and what the requirements are for us to get to that spot. For those of you familiar with 21st Century Cures, that legislation was passed a few years ago and really required us as an organization to look at how we were providing data access to not only our patients, but also to our partners and even payers, and how we wanted to create an environment and create a technology solution that enabled those patients to get their information as well as those other constituents interested in connecting with us. So USCDCI is the U.S. Core Data for Interoperability. Essentially, the ONC has, through regulation, defined what data you need to make available. And really the big focus is on information blocking and making that data available for patients. So instead of having the ability to log into your portal and looking at the information that you've provided to them, really the API access, it provides direct access to the discrete data and requires you to make that information available. Most organizations are leveraging their EHR technology, but as you look at the entirety of the information that needs to be available to patients, all that information may or may not be available in your EHR, and so relying solely on that to comply with the regulation is probably a little short-sighted for organizations, and you really want to think through your strategy for making that data available. And as you can see here, the legislation timeline has passed, so if you weren't complying in April of 21, then you have some work to do there. But really what you want to make sure of is that you understand the regulations. Obviously, May of 21 was the admit, discharge, transfer notifications for primary care providers. A lot of organizations were already doing that. There's a lot of directory management around that, making sure you have addresses on file for providers in the community that want to get that information about their patients that are admitted to your organization. And then May of 22, again, that's the data that's available for those patients needs to be available electronically. And USCDCI version 1 is out, and they're working through 2 and 3. And again, their regulation is going to give you that information about what you need to make available. And so I'm going to just give you a sense of what we've looked at and really what's available today for our patients and our community members. So one of the things about the API availability of information is a lot of that ties into notes. So problems, medications, allergies, some of those things were already available via API for our patients. But really, organizationally, we had to go through the process of turning on our open notes Open Notes is essentially taking the information that's documented in an encounter and making that available to the patient. So some of that even wasn't available in the patient portal. So that was an initiative here at UC Davis to open up the chart, to make all of that information available, and really to train the physicians about the charting process and ensuring that they're not including information that may get to the patient that they might be concerned about. So there's a lot of education and information around our legal and compliance processes that led us through that Open Notes implementation. So when you look at that, we have the ability through the legislation to look at things like sensitive encounter notes, things where a provider believes that that information might cause harm to the patient. So we do have some workflows and processes internally that allows the clinician to make that decision at the time of note-taking or documentation. But there are, again, policies and procedures behind that. So although there is an exception process, you really want to make sure you have that governance process in the back end with organizational policy procedures that outline what circumstances are approved or not approved for a clinician to make that individual decision at the time of care. Again, most test results are immediately available. We actually, part of the implementation, one of the interesting things is we were actually having inpatient, so patients that are actually in the hospital getting access to their lab or radiology results prior to the physician rounding. So that was an interesting offshoot of the regulation and making that information available. So as opposed to being held or having a time release, which is basically what we've been doing before, we're making those available right away. Now, there still are some things, cancer diagnoses, HIV status, some things that we might want to make, some care decision around. And again, that follows the exemption in policy. But essentially, all of that information is available, and a patient that might use a third-party application, I'll talk about that in a minute, has the ability to use their online account. For us, we use Epic and MyChart. So using their MyChart account, they can use any application that accesses our FHIR endpoint and get information, that information discreetly. On the right-hand side shows you some of the information, including allergies, vital signs, smoking status, immunizations. Obviously, with COVID vaccines, the immunization status has been pretty important. We've enhanced some of that capability with the Smart Health Card, but again, that information is available discreetly for patients to download into any application that they choose. You've heard about Apple Health Kit and others that information is available. To give you a little more detail, so we really looked at it in two phases. The USCDCI, so that April regulation required us to make all of these things available. Again, I talked a little bit about the clinical notes, consults, lab narrative, discharge summary, pathology reports, H&Ps, procedural notes. Again, all of these things some of those things were available before clinic notes were opened up through the Open Notes process. But again, you want to make sure you understand from a policy standpoint and from a process standpoint and from an education standpoint with your providers that you've really made it clear that that information that's charted is going to be available and seen by the patient. So now I want to talk about really our journey. So this is a slide that I included to kind of, because it has the date stamp on it. I'm not the best with Visio or PowerPoint, so I like to draw boxes and arrows to kind of give me my schematic. But really what we're looking at here is an enterprise service bus. Healthcare technology, or really technology vendors in general, like to take the same technology or same strategy, pub sub, enterprise service bus, cloud enabled. Those are the same sorts of technologies that have been around, have just been rebranded or adopted by new vendors like Amazon and Microsoft. But we've been using the similar concepts for a long time. And really for our journey, we were looking at creating a single point of access and connectivity for our applications and our external and internal vendors. So that service bus was key to that strategy to connect not only those applications, but those applications via API, and really that new technology, that web enablement of that data within our system, connecting with our Epic environment, connecting our web environments, connecting our remote patient monitoring applications. We had a research project that was connecting diabetics with their Fitbit to monitor activity. So we were connecting to that via API and bringing it back into our ecosystem, connecting it to Epic, our research folks, for that data access. Apple Health Kit, Propeller, which is a remote patient monitoring for asthmatics, for being in Northern California. If you don't watch the news, we have a pretty significant fire season, not a lot of rain in Northern California, and that Propeller application actually allows asthmatics to, when they use their inhaler, that information comes back to their clinician. And so maybe their medication's not correct, or maybe they're using their inhaler a lot and need to be seen. So that connecting these types of applications allows our physicians to have a more constant contact with our patients. This enabling technology and the APIs that have been deployed here will provide that access in very specific use cases, but also in wider use cases like Apple Health Kit. It allows you to download your entire, a good portion of your medical record to your phone. One of the other pieces on the service bus is that the Epic APIs, we've licensed essentially every Epic API that's available, and really allows us to broker that connection for any of that information in Epic with our external partners, our patients, or anybody internal that might want to get access to that. So it's been a long journey. 2 years through the pandemic has felt like a long time, but it's really been key to our strategy of being prepared and understanding what we want to do and where we want to go. So now, as you can see, I didn't create this slide because it's a lot nicer, but it really gives you a sense of the architecture or infrastructure or the entirety of the vision here. So our enterprise API strategy as we move forward really looks at what constituents we want to make sure have access to data. So we talk about patients. Obviously, that's the first person, really looking at patient-centered care here at UC Davis, and we want to make sure we enable that access for those patients. We also have a lot of partners, and again, because I like alliteration, I've lumped a bunch of folks into partners, but really partners are application vendors, they're local healthcare organizations where we want to connect with them. We want to make sure that data access is easy, that interaction is frictionless. I'll probably use frictionless too much, but again, what we want to make sure is the data is available, the ability to access that information is real time, and those APIs have been deployed in such a way that it's secure and allows those partners and vendors to connect with us quickly. And then payers, and really that's I'll call it a burgeoning community. There's a number of different efforts with the Da Vinci project and CAQH that we're involved with that allows us to walk through those interactions with payers that are more difficult, like the referral and authorization process. Because we're an academic medical center, we get a lot of referrals from community providers for our specialists. And that process is somewhat cumbersome because the technology on the referring provider side may be different or may be difficult for them to access. We still get a lot more faxes than we would like to think about. And so really creating an environment with our payers where if we were to get a referral, we can actually process that more quickly, allow for a lot of automation and making those APIs available and those use cases deployed in our infrastructure will help us to support more activity, more referrals, and really take some of the burden off of those referring small community providers that aren't so technically savvy and really help us enable that real-time connection with our payers, eliminate some of the clearinghouses that we work through now, and really as they are part of this 21st Century Cures Act, they're API enabling their side of the equation, we're API enabling our side of the equation, and then really that seamless direct connect will help improve access to care, quality of care for our patients. So when we look at this, the galaxy of things that we can connect, obviously you've got your television, you've got your sensors, you've got your mobile device, and really our current state is that our patients can connect to Epic APIs directly. Essentially, partners can connect through the Epic App Orchard, which requires some process with Epic. And really today we're working through that process of getting payers connected, but we haven't essentially implemented. We have a couple pilots going right now, but really what we're trying to do is move ourselves from our current state to a future state where we've enabled all the APIs. We have good partnerships where we can deploy those APIs through our pilots that we're doing today with Centene and InterSystems to connect them through that referral and auth use case, really all of the Da Vinci use cases we're working through. And because we have to make that data available via API for 21st Century Cures, not all those systems are connected internally. Not all of the data in our organization that we need to make available is in Epic. And we really needed to make sure that we enabled that data for access. And so our business requirement here is to develop that capability. And that's really where, as we move forward, and looking at what's connected today, these are the applications that we have connected today through internal. So our Ensemble and UC Davis Health Share, the Epic App Orchard. So those are applications that have been vetted by Epic and essentially connect through their interconnect server. And then the Open.Epic. This is really the 21st Century Cures access. So these are patient health records, for lack of a better way to say it, the old PHRs, where those patients are using their digital credentials to log in and actually download their information into that PHR record. And again, I expect the list on the right to continue to grow. So for us, the future strategy is, again, making sure that we can connect all three of those constituents or more. Again, my alliteration probably widens the pool of things that we can consider partners that allow us to not only to connect, but continue to support that patient direct connection. We'll continue to support our Epic App Orchard environment because there's a lot of investment for those vendors in a seamless connection with Epic. But not all vendors will go through that process. Not all connections that we'll need to support will go through the Epic App Orchard. And really our ability to have the technology and the solution to build those connections, to support those. We've got a couple of different pilots that I've listed out here, but essentially that access, that OAuth credentialing, ensuring we can manage those accesses and get that information available with the right security and with the right layering or filtering, so that their people are getting access, or organizations or applications are getting access to the data that they need at the time that they need it. And really, this is just again, my great PowerPoint skills here that show really what we're looking at is when we look at the different, on the left-hand side, you see the different constituents here, the patient apps, you've got your partner or vendor apps, you've got your payers, and I included even the credit card payments, So, what we're doing today with some of the interaction with batch processing and payment processing, really making those APIs available to receive payments. I show here, you got the Apple Health, you got the little heart, you got the Fitbit app, MyFitnessPal. Again, those patient apps are really going to explode, where patients are going to get access to their data, and then those essentially applications are going to layer on functionality or capability for those patients to see value in that data that's available to them, and not only connect with UC Davis, but connect with other organizations and have essentially a longitudinal care record at their fingertips. And then those partners, again, we got remote patient monitoring, we got Gluco and Typool, we've got our digital app formulary through Node Health, where we're doing remote patient monitoring and access mechanisms. And as we move to the right, really, this is the infrastructure that's going to support that. So we've got our API gateway through API Manager that allows us to build those connections, publish FHIR endpoints, broker those transactions. We've got our health share environment that's going to help us with storing some of that information, especially for those applications that aren't currently connected via API, like our non-Epic financials or non-Epic clinicals or any internal applications. Really, this gateway is going to enable and API enable all of our data to be available outside of our firewall. And then Iris for Health really is the core technology that does all of our messaging on the back end. But really, this is the vision of enabling API, enabling all of our information, providing a secure connection and managing that in a central point so that we have the flexibility to connect with and provide that functionality to our partners. Really, that's our end game. We're still in the first quarter. If you look at it as a football game, we're in the first quarter of this journey. We've got a vision. We've started those pilot programs. We've executed part of that on that strategy with finding the right partners and working on the right pilot programs. And as we move forward, we'll see more and more value and more use cases that come to our door. And I think it's a very exciting time at UC Davis to be walking this path. So very excited to share our story. I really appreciate the InterSystems inviting me to share what we're doing here at UC Davis, and I'm happy to answer any questions. So thank you, Linda.
Thank you, Michael. I always enjoy listening to your presentations. So my first question for you is, when you think about what the front door looks like from different perspectives. So if I'm a patient, or I'm a partner, whether at a vendor partner or another provider organization, or I'm an insurance company, a payer coming to your front door, what does that look like, from those different personas?
From our perspective, or at least from my perspective, what we wanted to do is actually be the same. We want that engagement from external to be really driven through, you hear the term single pane of glass, you want to hear the terms frictionless. Really what we want to do is enable, based on who you are and what your role is coming to our organization, to enable our front door to essentially provide a view into the information, applications, and functionality that you should have access to based on who you're logging in as. So, you might be a physician who's also a patient. So essentially, and this is an account management piece or a role-based piece, but you have two different roles, and you might have two different access methodologies, and those access methodologies may provide you access to different information. And really for us, what we want to do is make it, from a community resource standpoint, seamless. So if I come in as a physician, there's specific capabilities and functionality and information that I want to have access to about patients that I may have referred, or patients that have been in the ED that they want to see a post-visit summary, and really being able to allowing and enabling that access from whatever their source system is. And really that's been a point of contention. There's been a lot of portal applications that make information available to these community providers, but it requires them to log on in different ways. We're hoping to set this up so that you can use an existing account that you may have to log in, so that it allows us to provision that access to the information that you have available, and really enable you to take that information and bring it into whatever source system that it makes the most sense to you. So if you're a community provider and you have an EHR that's enabled to accept data via API, then you can request, and that's how the API process really works, is you can log in, you can request information about whatever patient that you want to request information from, and then that can deliver that API data via API back to your system so that you can consume it and use it however you see fit. And really that's the way we're looking at it, is that the digital front door, depending on who you come in at, what your role is, whether you're a patient or a provider or even an insurance company, is we're going to provide you an access point that's going to give you access to the information, or maybe even capabilities within the organization to request information or to participate or engage in care activities with us. And that information is going to be available for you to take with you and use natively in whatever application. And really that's, for our organization, you look at a digital front door in a couple different ways. One is really providing community-based access and information in an easy and intuitive way to all the capabilities and different systems we have on the backside, right? From my perspective as the interop guy, it's really is how do we make data and information available in a seamless and interactive way to those community members based on how they're coming to the organization and what they're looking for. So the organizational strategy kind of has two pieces. One is really capability and information access to care, and how people will come in and get to that touch point. My view on that is I want to do the same thing, but with information. So depending on how they're coming into our organization and what information they're looking for and their role, we'll be able to enable that information via API and provide that to them in a content and manner. We talked about that earlier. The content and manner that they want, and again, this is really API enabling that data and that access. So
that's a great answer. I love that, because again, you really want that front door to be open to anybody. So now let's move on. You and I have chatted that you have I wouldn't call it as new CIO, but relatively new CIO at UC Davis. How has that changed, or how has that helped with your journey and your strategy, Michael?
yeah, Linda, it's a very interesting question, because you think about the culture change that comes with a new CIO. Dr. Treja comes with a very innovation-centered mindset. He's part of the Node Health team and has done a lot of work in innovation. And really, he comes with a forward-looking perspective in saying, how do we solve problems? How do we solve problems with technology? He actually came in and rebranded our information technology group to the innovation technology group. So if you get an email from me and you see the tagline, you'll see UC Davis Health Innovation Technology. And I think part of what we've been doing with our interop group and with the APIs is we've really been working in the background meeting business need. Somebody comes with a solution that has an API-enabled application, and we've really been going through and working through that deployment and making that available. The strategy through USCDCI or the 21st Century Cures Act really required us to be forward-thinking and saying, how would we provide solutions for patients and for those other constituents that may want to get access for data? Really what Dr. Treja's mindset in that innovation is saying, okay, how do we take that to the next level? How do we lead from the healthcare space into this data liquidity, is looking at all these different use cases, is extending ourselves out into the community via this API enablement of data, and really looking at those innovative use cases. Remote patient monitoring, I wouldn't say is the most innovative thing. We've been doing that for a long time, but really taking real-time decision support, bringing that data back in the organization, maybe even leveraging AI or doing different things with that information that allows us to care for a larger population of patients more dynamically. And again, that precision medicine, we've heard precision medicine for a long time, but really that's a focus on specific data for specific patients with specific conditions and really leveraging technology and advancing technology for those use cases. And I think his mindset of being innovative and looking at things in a new way, and again, being a leading organization in technology, is really looking at the culture at UC Davis that has been, a leading organization from a research standpoint, and really taking that and trying to be a leading organization in the IT space. And I think that culture, that mindset, that if you've heard Dr. Tracy talk, he has a lot of energy, does a lot of speaking, and I think he's really invested in that and is really bringing that culture here. And I think that helps us move forward with this mission that we've been doing kind of on the backside because of the regulation, really now makes it kind of an organizational imperative.
Yeah, and I would say that in the industry, that's probably something we're going to see more of, that we have to see more of for folks to be able to move forward with everything that's happening sort of in the healthcare ecosystem with the regulations and the data sharing. So last question for you today. Who are your champions and your stakeholders? Nothing gets driven in any organization sort of from within the IT organizations. It's always the business or the environment or both that are sort of driving where you're going and where you're headed. So who are some of your big champions and how are they driving where you're going?
Yeah, that's a good question, Linda. Part of I would say the initial start was really looking from an IT standpoint for me as we'll call it a visionary, or visioning where our organization would go. And part of that was really just FHIR APIs. Our group, and I'm not answering your question, but I'll get there. Our group was really focused on version 2 HL7. And so what I saw from an industry standpoint is that, FHIR APIs are coming. How do I transition my staff from doing things in the version 2 way to the FHIR way? So looking at the technology, the trends, and then the regulation. And really that's where you get to the business partner, right? The regulation shows up and says, you shall do things with APIs. So early start was our CMIO, Dr. Wada, and our HIM and compliance groups. They're the ones that are providing that information to patients today through release of information processes, or really some of the technology pieces with our physician champions and saying, okay, we need to move to open notes. So those were our early partners in saying, okay, to meet the rules of the regulations, we've got to make these technology changes. We need to enable these things organizationally. Kind of the phase 2 on this has really been looking at those use cases that are things like the referral coordination. I talked about that earlier. So the referral auth process. We get referrals into our organization via fax, via phone, via email. So our group that manages referrals, our patient contact center, our physician liaisons, our community liaisons that are working with these referring physicians, what ends up happening is that we've been trying to drive them to leverage Physician Connect, which is a portal product that they can log into and see activity. But really what they want to do is work natively in their application. And so enabling the APIs for them to provide that referral to us electronically, for us to provide them status updates and information about that patient visit electronically via these APIs, that really now is kind of, I'll call it a leading use case. We have a lot of time and money invested in that, bringing those patients in and being a community resource for providers in the community. So ensuring that, and again, for whatever reason, my brain is stuck on frictionless. So, making that engagement frictionless, allowing that provider to refer a patient that needs specialty care at an academic medical center as the community resource, making that frictionless, making sure that communication back with them is seamless, and not requiring extra steps or things for them to do, or extra logins, or things that really don't help with that care, that make, we talked about click fatigue and alert fatigue for physicians, really trying to enable technology to allow that to happen without a lot of additional steps or interactions for the provider, and for them to get the information they need. So I think that for right now, that's our biggest driver, our biggest constituent internally that's driving us forward with the API access. We also have our revenue integrity group that is looking at some of our costs and revenue recognition processes with payers. So trying, again, the referral process or the authorization side, getting claims payment, claim statuses, things like that, that today we're doing either through clearinghouse or through some other mechanisms. Again, as the payers are enabling APIs on their side, really leveraging that infrastructure that they're deploying and allowing us to do those direct connects to get the clearinghouses out of the way and really try to make that turnaround time a lot quicker for our organization from a revenue standpoint and from a claims processing standpoint. And not all of that data allows us to implement more automation. So, you might want to call it RPA. To me, it's just kind of a rules-based engine that allows us through the technology. Now that we've got this data flowing through our technology, we can now start applying rules. So on the referral use case, if a provider sends us a referral that doesn't have all the information we need, now that we're receiving that electronically and not via fax, we can apply a rule that says, oh, Dr. Jones doesn't have the insurance information. Send Dr. Jones a message saying, we can't accept this referral, we need this insurance information, or whatever it is. And that mechanism today, when they send a fax, isn't in place. By receiving that electronically, that'll allow us to apply rules and just, you can look at that exponentially, the different kinds of rules and rule sets that we can deploy because we have this interaction. And so those are our, revenue integrity, our HIM group, legal and compliance, our CMIO. Those are all champions in the direction we're going to not only meet the regulatory and compliance pieces of this, but also really the functionality and the capability that move us forward and really allow our staff to focus on higher level or higher complex activities because we have that data coming in electronically.
Great. Thanks so much. I always enjoy our conversations.
Yeah.
I always learn something new every time we talk, Michael. So thank you so much. And thank you to our audience.
Thank you, Linda. It's been fun. Appreciate it.
Thank you for joining us today. If you want to follow up or you have further questions, the best way to reach us is to contact me, Linda Rowe. I can be reached at linda.rowe@intersystems.com. I can also be reached on Twitter or through LinkedIn. Thank you, everyone.